you so much for connecting and joining us yet again for another very important session. And this time we'll be talking about Dolutegravir in pregnancy, another very, very important topic as we are providing care to the special population and that is among our women, those that are pregnant. I want to recognize all those that have connected in from across the country. And we have different people that have come in, Northern Province, Southern Province, Wapula, they are all connected. Thank you so much for joining us. I will be mentioning you as we go along in this session. Thank you so much. I also want to recognize our expert for this afternoon, and this is Dr. Albert Mwango. Dr. Albert Mwango, kindly unmute yourself and just say hello to the network.
Very good afternoon, Dr. Hosea, and good afternoon to the network.
Thank you so much. I would like also to acknowledge the provincial sub-hubs, Dr. Chimika Piri, Dr. Kevin Zimba. We have got, I don't know, Dr. Nyako, Dr. Lusa in Eastern Province, and we've got Dr. Chipasha and Dr. Mshisha in Western Province. Thank you so much for joining us and for controlling things out there. We are very happy that you were able to join us today. We'll give you an opportunity to say hello to the network as we go along. Thank you so much. We also have our experts that have joined us who will be helping us facilitate. We have different experts that some have joined, some are yet to join us. We have got Dr. Priscilla Mlenga, who will be joining us. We've got Dr. Sombo Foloshi, Dr. Ziko, Dr. Chitalu Chanda, as well as some of our Mrs. Gertrude Banda, and then also we have Mrs. Joyce Mwanangombe. They're some of the experts that will be joining us this afternoon. Thank you so much. And so before we get into our presentation for this afternoon, I'm going to invite Madam Nomsa to give us a recap of what we had discussed last week. It was another very interesting presentation that we had last week. So Nomsa, are you there? Hello, Nomsa. Okay, she may have not connected in yet. So I think at this time, we'll just proceed and move on to start our presentation. I know we're working with very limited time. We are trying to make sure that all the sub-hub, the provincial teams will have an opportunity to be able to share. So we'll proceed straight into our didactic presentation for this afternoon. And so I will be able to share our presentation, and then Dr. Mwango, perhaps Dr. Mwango, you wanted to share, or we can go ahead and share from here.
Dr. Mwango, unmute yourself.
Right. If you don't mind, I could share.
All right. So, okay, then I'll stop sharing, then you can go ahead and share. Then I'll be able to pick it up when we get to the pause. So please, may you proceed, introduce yourself, and then also you go ahead with the presentation. Thank you so much.
Thank you so much. Right, I hope we are all now able to get that.
We can hear you loud and clear, and then we can also see the presentation.
Thank you. I'll get started now. Well, thank you so much for giving me this opportunity to talk about an important area of our service provision to a very special group of pregnant women. We'll look at how DTG is being applied in this area. Just a little bit on the background about myself. I'm Deputy Chief of Party Technical at CRS EPIC 390 project, and I have no conflict of interest or disclosure to declare. Our learning objectives are very clear and concise. We'll be looking at the current recommendations of DTG in pregnancy. We'll also describe pregnancy and birth outcomes following DTG exposure, and wrap up by looking at DTG efficacy in pregnancy. As a background, I think the goals for ART in pregnancy are very clear. Largely, we would like to optimize maternal health when we give ART. We would like to maximize the risk, minimize the risk of perinatal HIV transmission, and also look at how we can prevent sexual transmission to the uninfected partner. These are the traditional goals of ART in pregnancy, but additionally, I would like to also emphasize that an additional goal, which is sometimes neglected, is that of minimizing adverse pregnancy and birth outcomes. We've had DTG in Zambia for the last almost 2 years now. And since July 2018, this was introduced on our formulary, and we've been providing DTG to women who are pregnant. And it started off with a lot of discussions and issues with the outcomes of information from Sepamo in Botswana. So since that time, we are going to review what has changed with this new drug for this population specifically. WHO recommends first-line ART for adults and adolescents, which includes pregnant women, to be DTG given with 3-TC or FTC and tenofovir, TDF. The caveat to this recommendation is that DTG can be prescribed at any time, depending on the patient's wish. And if you're looking at the woman who's pregnant or is desiring to be pregnant, this can be given at any time, provided that individual is provided with full information on some of the risks and the benefits, of course, of DTG. This is known as the woman-centered approach, and this is what WHO has been recommending. If we move to our guidelines, the Zambia Consolidated Guidelines for 2020, TLD, which contains DTG, Dolutegravir, is also the preferred first line for treatment of pregnant and breastfeeding women. So the same drugs that WHO are recommending are the same drugs that we are also recommending in the country. And we also, if you look in the details of this recommendation, we recommend a woman-centered approach in which a woman is counseled of the benefits and the minimal risks of DTG during the time of periconception or when the woman is pregnant. And this is based on a woman's choice. So if she has enough information, she can make that decision on her own, and that will be respected. So this is just reflecting the same recommendations that WHO has, and these are recommendations in Zambia. I've put this slide here for us to just review the evolution of DTG in women. When we started off in 2018, I reviewed also these guidelines and looked at exactly how we were recommending DTG. Just to orient people to the chart, the green shaded areas imply that DTG can be used. The red implies that DTG should not be used. And the orange implies that we need to switch from DTG to another option. And then the blue area implies that there's need for expert opinion, as this was not in the guidelines. So here you're seeing the DHHS, which is the American guidelines, and also the BHIVA, which is the British guidelines, and then WHO guidelines, and then the fourth column there is the 2018 guidelines, as they were for Zambia in 2018. And then we'll also look at how things have changed with the 2020 guidelines. So you can see what I want just to bring attention is that there are different situations. A woman could be taking DTG or not, and then she might be in any of these states of pregnancy. She could be in early pregnancy, late pregnancy. She would be of childbearing potential and not on contraceptive, or childbearing potential and has contraceptive. And then those are the different states. And this is what the guidelines recommend. As you can see, just to bring it to your attention, there's a lot of red there. And then in 2018, there was also a need of expert opinion just to make some decisions on certain guidelines. Now, this is 2020, a similar review of all these guidelines, and you can see that the reds have dropped off significantly, and we have more green, which is implying that DTG can be used in nearly all the different states, with a few exceptions from certain guidelines here and there. But as you can see, the 2020 guideline shows there that it's all green, and the only emphasis really is that if someone wants to be pregnant and they are considering DTG, they have to be provided with information on the risks and the benefits, and their decision should be respected, which is the woman-centered approach. So that's what FI stands for, all of their. WHO really emphasizes this. The Zambian guidelines also emphasize this. The need for experts has also moved away. We don't need a lot of experts to actually make this decision, which is making it much easier for us to give DTG. In the British guidelines, there's also a need for folic acid to be given at certain times of pregnancy, whether it's early pregnancy or someone is trying to get pregnant. There is a need to provide folic acid as a precaution. So those are the new changes, but overall you can see that it's more permissive. There's more green recommendations to use DTG. Right. We will stop here for a polling question, which is the first one. And this first one is basically a simple question asking us what the preferred regimen for pregnant women in Zambia is.
All right, so this question here, what is the preferred regimen for pregnant women in Zambia? We have an option A, TDF, 3TC, or efavirenz 400, or B, TDF, 3TC, DTG, or ABC, 3TC, DTG, or TAF, FTC, DTG. So we are inviting the network to participate and pick out the best answer. So far, I can see only about 42% of people have voted. We have about 200 connections, so we're expecting a lot of participation. Okay. So I'm giving you a little bit more time. I'm sure just trying to acclimatize to the time now. Okay, 5 seconds more. And I will end the poll here. So Dr. Mwango, I'll just share how the people have voted today so that you can just see what this looks like. So according to how people have voted, most of the people think B is the correct answer. Few of them would think that A is correct, while others, very few think D or C are correct. So I know you ran us through the answers as you give us this presentation and at the end of the presentation. Okay, thank you so much. I think you can proceed, Dr. Mwango, with the rest of the presentation.
Thank you so much. So we'll definitely come back to that. So we'll now look at an area where we list do quite a lot of work in terms of HIV program monitoring. This is pregnancy and birth outcomes. And then specifically looking at those that have been exposed to DTG. This has become an important area largely because of this alert that came up in May 2018, just when we were launching the use of TLD in Zambia. There's a study, a surveillance study known as SEPAMO, which looked at birth outcomes amongst women who were living in Botswana, who were HIV positive, and some of them were HIV negative. So it was following up both conditions, those with HIV and those without HIV. And in May 2018, an unplanned interim evaluation revealed that there were 4 NTDs that were identified among infants born to 426 women that had taken DTG at the time of conception. Now, this translated into a 0.94% of prevalence of neurotube defects, which was quite alarming at that time because that was 13 times the normal background. And the normal background we're referring to is NTDs in HIV negative women. And that was at a level of 0.07%. So this was quite high, and this caused a bit of a stir in the fraternity for providing this highly efficacious drug to women who are pregnant. So that raised some concerns. So we follow through on the SEPAMO study, and a year later, July 2019, more results were presented and shared to the rest of the world. So this chart basically tells us the prevalence depending on what the woman was taking at the time of conception or during pregnancy, meaning after the conception period, or if that woman was HIV negative. So we can see that the prevalence had dropped from the initial high levels to 0.3% for those women who are on DTG during the period of conception. For those that were on other ARVs, which are not DTG based, it was at 0.1%. For those on efavirenz, it was lower at 0.04%. And those that had started DTG after the first, if we can say, after the peri-conception period, which would be anytime after 6 weeks, second trimester, third trimester, we find that the neurotube defects prevalence is at 0.03%, very low, even lower than those that are HIV negative, which was at 0.08, which is the background. So you can see that with time, as the surveillance was progressing, that original alarm went down to 0.3%, which is quite reassuring for those that are proponents of giving DTG in pregnancy. So this continued, and in this slide we are seeing this the similar analysis, but this is at the time frame of April 2020, which is a couple of months ago. And you can see what is very key here is that prevalence for DTG has actually dropped to 0.19. So from as high as 0.94, it has dropped to 0.19, which is approximately 0.2. And you can see compared to the other conditions or situations, non-DTG exposure at conception time was 0.11%. To efavirenz was 0.07, which is almost the same as the background, which is the HIV negative woman. And for DTG in pregnancy, so meaning outside the periconception period, it was even very, very much lower at 0.04. So we can see a lot of things here that with continued surveillance, we are beginning to see that DTG effects on pregnancy is not as risky as even compared to the other situations or as the original levels. And we also see that DTG exposure during pregnancy outside the periconception period poses very, very minimal risk to the woman who's taking this and the child at the level of 0.04. So these are some of the takeaway messages you can get from this slide, in that the risk has reduced significantly, and also that DTG in pregnancy really has very minimum risks, even much less than those that are HIV negative. And we are assuming that those that are HIV negative are not taking ARVs. So you can see that's the situation we're at right now. This is the latest information from Sepamo, Botswana, and was shared in April 2020 at the quorum. So before initiating integrase inhibitors in a woman with childbearing, or childbearing potential, we should always test that woman for pregnancy. So let's not make assumptions because all women would like to have their options and they would like to know exactly everything that is happening before you start DTG. That's the only way we can provide this informed information, is if we have it, we test women if they're pregnant or not. And then when we are giving them those options, please do mention that it's a very low risk to get neurotube defects from DTG, especially if it is outside the periconception period. So this is the information that is required to be shared with all women as we are initiating them on DTG or any other integrase inhibitor. So what are some of the things that we should be thinking about or be might be concerned about, which might lead to neurotube defects? Because these women did develop neurotube defects in their infants. And what is it that could have been changed? What were the risks at hand that would be considered? One of the key things is nutritional status. Maybe they have got folate insufficiencies. If this is present, the chances are fourfold in terms of increasing neurotube defects. If the mother has diabetes, this has got a very high risk, which can range from as low as 2, but to as high as 10 times the normal background. And then for maternal obesity, if mother has got high BMI, this can increase the risk to up to 3.5 times. If the mother has got hypothermia, maybe as a result of fevers, she's having a febrile illness during the periconception period, this can raise the risk to about 2 times. And then of significance is if the woman is taking valproate, which is a drug used for controlling certain types of epilepsy, absence seizures. This can go up to as high as 10 times. So this is some of the modifiable risks that we know of that can be controlled to some extent and avoided so that the woman does not end up with a neurotube defect pregnancy. Right, so what I alluded to earlier on is that the HIV program has not really monitored well pregnancy outcomes and birth outcomes, in that we don't routinely report this. We have very minimal information in many settings, especially our settings in Zambia. I had a tough time just trying to get information which is local and to just demonstrate what our birth outcomes are like in our setting. So what I'll share in a short while is just based on what has been happening in countries nearby or close to our setting. We usually just think of congenital defects like the neurotube defects, and other maternal organ dysfunctions, like maybe she gets a liver problem, a kidney problem. Those are some of the safety issues we usually think of, but we don't really think much about the birth outcomes. And this is what I would like to bring to the fore in this presentation, that we need to be mindful of this. So what are these pregnancy and birth outcomes we are concerned with? These are the definitions that are used generally. We may have induced abortions, we may have spontaneous abortion, low birth weight, very low birth weight, small for gestational age, which is very specific to regions, preterm birth and stillbirth. So these are the pregnancy and birth outcomes that are of concern, because the drugs that we're giving to these pregnant women can affect these outcomes. Right, so the first study I'll share with you now is a study out of Lesotho, which is a country nearest to our environment. However, Lesotho has got very high prevalence of HIV. But what they did there is they looked at outcomes from women who were HIV negative compared to those that are HIV positive and on ART. And generally, you can see that the composite outcomes were much higher in HIV positive women on ART at 20.7% compared to 10.8%. So we, in other words, we're saying we see more of these problems in women who are HIV positive and on ART than those that are HIV negative. And then if we break down those problems, we start seeing them, coming out almost at all times with significant statistical significance, that there are more in the HIV positive groups. For instance, intrauterine death overall is 7.8 compared to 2.3 if you compare positive to negative women. And so that means HIV and ART are causing quite a significant, albeit clinical, a significant outcome of intrauterine death overall. Right, so we will stop over for another polling question, just to see how much attentive we've been. And this question, Dr. Ziambo can assist in moderating this.
Thank you so much, Dr. Mwango. This question says, which of the following has a high risk of neurotube defects? Which of the following has a high risk of neurotube defects? Maternal hypothermia, inadequate maternal nutrition, maternal obesity, drugs such as valproate. Which of the following has a high risk of neurotube defects? Maternal hypothermia, inadequate maternal nutrition, maternal obesity, drugs, e.g. valproate. Okay. So we have about 246 connections. Very impressive today. So many people have connected. We're happy and we're expecting a lot of participation. So please go ahead and poll in the next in this particular poll question. There's about 55% participation. Okay, I think our time limit has finished. It's been 1 minute, 30 seconds. So I'll end the poll here. So I'll share what the results look like. So most people think it is B. Some people also think that it's valproate. And a few think it's hyperthemia in the mother or obesity in the mother. So I think so far, that's how we are doing. So I think we'll allow Dr. Mwango to proceed. I just want to remind you, Dr. Mwango, that we're only remaining with about 8 minutes of your time. Thank you.
Yeah. Thank you so much. I'll be wrapping up shortly. This is the last segment. Thank you. And thank you for all the responses. We'll get to them in a while. So at this point, we'll look at safety. One of the key studies that have actually taught us quite a lot about safety of DTG compared to efavirenz in pregnancy is the Dolphin-2 study. There was the Dolphin-1 study, which basically was a pharmacokinetic study. And then the Dolphin-2 went into more specifics. And based on the discussion we have today, what we are looking at is that when we compare DTG to efavirenz, we find that there's quite some significant differences between these two studies. Of note is that DTG-based ART has got quite a higher number of preterm births compared to efavirenz-based regimen. And then also adverse events are slightly higher for DTG-based regimen than efavirenz-based ART. And the reason I'm sharing this information is really to underscore this particular finding of higher adverse events and deaths when we use DTG. We need to be monitoring a little bit closely when it comes to safety of the pregnancy, these outcomes, and see if this is valid within the clinical setting. This is from studies, so it may be slightly different from the clinical setting. So we need to just keep an eye on that. And these differences are statistically significant. And then for efficacy, how well these drugs work, the Dolphin-1 also showed that. That was one of the things that the endpoints of Dolphin-1, apart from the pharmacokinetics, was to show how effective DTG works compared to efavirenz. And in this chart, we see that a lot of the DTG-based regimens brought about viral suppression much earlier by about 40 days, 30 to 40 days in the DTG group compared to efavirenz, which was really what was very encouraging about this drug, because it brought about viral suppression very quickly in those that use DTG compared to efavirenz. And we know that sometimes our women present very late, and hence we need to lower their viral loads very quickly before they deliver to prevent transmission. So this is a drug that really is a useful drug, DTG that is, to bring about this situation. Then here you can see the differences in terms of DTG compared to efavirenz as well, when it started after 28 weeks of gestation. And the blue chart bars there basically represent the number of women who had viral suppression compared to those in orange, red there, who were on efavirenz. You can see that it's far much higher, and they're all statistically different. So the first chart basically is what we are looking at here, which just shows how favorable DTG works when it comes to suppression. So this is why we are so fond of DTG, because of this effect in lowering the viral suppression of the viral loads. And another very important study which has come out is the Impact 2010. This is a study which came out early this year. I know it was overshadowed with COVID-19 issues, but it's a study which has shown even much more hope for us in that we should be able, going forth, there is some promise that it can be used with TAF. I saw some people were showing that TAF is a preferred drug. It's not as such. TDF-based regimens are the ones we should prefer. But this study showed some benefits of using TAF in pregnancy. And so this is also promising, but more evidence is required. And then this slide, which I have as I'm wrapping up, is now comparing all the different studies, including the Impact 2010, which just came out recently, comparing those that took DTG with those that took efavirenz. The first two bars are looking at suppression. Again, you can see 90% were suppressed compared to 72% of those that were on these two different based regimens. For stillbirths, you can see that for stillbirths, DTG had 4% and compared to 2% in efavirenz, but this was not statistically significant. So in other words, you can probably consider this as equal, or it doesn't say anything about which one is worse. Neonatal deaths, again, was not statistically significant in difference between the two drugs. MTCT as well, transmission that is, not statistically significant. And even mothers with more than one adverse event was not significant. But what was also looked at is the effect of these drugs when taken by the women in the infants. So basically we see that statistically they are not significant, these clinical outcomes between the two drugs. But what really trumps up is the viral load suppression, which is much higher than efavirenz. So this is what tips the balance. Right, so we'll stop over now for our final polling question, and then we can end this discussion. Dr. Ziam.
Okay, thank you very much. Very, very important points coming out, and we really appreciate the efforts made in this presentation. So the next question is, efavirenz is more efficacious than DTG? Efavirenz is more efficacious than DTG, that is, viral load drops faster. Is this true or false? Is this true or false? I can see a lot of participation for this one. Very straightforward, I can imagine. Okay. We have a few more seconds to poll. All right, I'll end the poll now. So this is how the network has voted. Most people think it's false, and very few think it's true. So stop sharing and just allow Dr. Mwango to proceed and give the final key points.
Right, thank you so much to everybody for that, have participated in that, and really it shows that the take-home points are going to stick, and these take-home messages or the key points are that DTG protects the health of the mother. That's very obvious. Neurotube defect risk from DTG is very low, and we can confidently say that even using the CEPAMO study numbers. DTG prevents transmission of HIV to the child. I didn't go into details of the transmission rates, but this is something that has been demonstrated with the same studies that I shared here. DTG reduces viral load faster than efavirenz, and that's something that we saw in the last few slides of this presentation. So just remember that that's a very key characteristic of DTG, and that's something that we want to have for our mothers. And then finally, pregnancy and birth outcomes need to be monitored. And the reason I say this is because some of the studies are showing some higher absolute numbers, although they are not significant, but that's something that should tell us we need to be watchful over the pregnancy and birth outcomes when we are using DTG as our preferred first line. And this last slide is basically just to alleviate any anxiety for those that were not sure what the answers were for the questions. But it is very clear our preferred regimen is TDF3TC with DTG. Not tough yet, although there's some evidence that is showing that that might be safe to use, but we don't have conclusive evidence on that. So our preferred one is the TLD. And then which of the following has the high risk of neurotube defects? As you saw, valproate and certain drugs have a very high risk, which is 10 times the normal. So this is from the options that we're given, this is the highest. So valproate is the highest. And then the final question, efavirenz is more efficacious than DTG. The answer is false. We saw in the last slides that DTG has got better viral suppression outcomes and it's faster. I end here. Dr. Ziambo. Thank you so much to everybody for your attention.
Thank you so much, Dr. Mwango, for this excellent presentation. Very, very important information to all of us who are in the practice, and it has reassured us that indeed DTG is actually safe to use in pregnancy. Of course, we need to make sure that we give that woman-centered care, ensuring that they are aware about what is the DTG is all about, and we offer them the treatment, and then we monitor the birth outcomes and whatever it is that surrounds the birth and delivery. Thank you very much. At this time, we are going now to invite the network to ask any questions, clarifications that you might be having. And I'm also appealing to the sub-hubs now to prepare themselves if they're ready to be able to do the presentation. Make sure your cases are nearby, then you can begin to share the cases. But in the meantime, we invite the network to ask questions. There was a hand earlier that I noted. Is it from Dube? There was a hand. I don't know if you still want to clarify your question. Questions from the network? Dr. Mwango, there was one question here that in the chat box, one person was asking, what is the effect of DTG on the HB in pregnancy? The effect of DTG on HB in pregnancy. Your comments on that one?
Right, thank you so much. That is one area which has not had any significant impact from DTG in the women that have been studied so far in these big studies. But of course, we never put away any possibility, and this is why we have continuous pharmacovigilance to see if anything does come up. Sometimes these things are triggered by combinations with other drugs and other situations or conditions. But so far, I have not seen any significant report which shows that DTG has got adverse effects on hemoglobin for patients who are receiving it.
All right, thank you very much. There was a hand, it has disappeared. I saw someone raise a hand and they want to make a comment. Please unmute yourself and ask your question before we transition to the breakout session. Is it Chiparamba? Chiparamba, please go ahead. Kasanangwa. Okay. Makasa Brian, go ahead and ask your question. Makasa Brian. Okay. What about Ken? I've seen a hand. Ken, would you like to go ahead and answer and ask your question? Okay, so far we don't have anyone coming up with any questions. So anyway, so we'll proceed on to our breakout sessions so that we can allow for more discussions within the breakout rooms. So we have got Dr. Zimba in Lusaka province, and then we'll also have, we want to recognize the expert in Lusaka province, Dr. Doug Watson and Dr. Sivile. Thank you so much for joining us. Then we'll have also Southern province with Dr. Chimika Piri, and we'll also have Dr. Nyaku, Eastern Province, and then also Dr. Chipasha in Western Province. So I'll ask our IT to just send us out into our breakout sessions. So they'll come, a prompt will come So just click on it and then it will take you to your breakout session in the province. Dr. Mwango, you will remain with us in the Southern Province as an expert. Thank you so much.
Thank you.
Mute your computer. Dr. Lusa, mute your computer. Mute your computer. Then you can use the teleconference there in the conference. So your computer should remain muted. Okay. So we have to do the case now, is it? Dr. Matua, are you ready? Where's Dr. Matua?
Yes, he's on the network.
I'm standing in for Dr. Matua.
Okay, please go ahead and present. You can see the screen.
Yes, can.
All right. Okay. So introduce yourself.
I'm John Male, clinical officer from MOH Zambia Clinic.
Thank you.
So the case before me is RP, female, 27 years, postnatal mother, delivered on 2nd June 2019 SBD, diagnosed during first ANC booking on 4th February 2019, started treatment the same day, that was TOE. Viral done at 6 months was suppressed, that was 209 copies per mil. It was done on September 24th. Then the woman was switched to TOD because at the time we were transitioning from TOE to TOD, all those that had suppressed viral load. So repeat viral load was done at 1 year, which came out as target not detected. That was in June this year, 2020. Then we switched back to TOE because we had the shortage of Dolutegravir, TOD, I mean, at that time because of the issues of COVID coming in. So this woman currently is still breastfeeding, and the child DBS was done at 6 weeks, which came out negative. The rapid test was done at 9 months, which wasn't included in the presentation. It was negative. Then at 1 year, 6 again, we did the rapid test, which came out still negative. The child received AZT, 3TC, and nevirapine for 6 weeks. Then currently, the child is on Septrin and clinically looking fit. Next slide. Yeah. So on physical examination, the general appearance of the mother is stable, vital signs in the normal ranges, no skin lesions, no lymphadenopathies, no ganomegaly, then whose stage is still in stage 1, clinical fit. The appearance for the baby, stable, normal growth at the age, no skin lesion, looks healthy and clinical fit. So this summary of the treatment that we initiated. The first treatment was TOE, initiated in February 2019. The viral load by then, when we did it, was 209 copies per mil.
Does this it was split?
Then TOD was initiated in October 2019. Up to date, the viral load was 0 copies. Then this year in June, we transitioned again to TOD because the TOE, there was a guidance that all those who have been on treatment for a year plus and they've got viral suppressed should continue on TOE because of shortage of TOD. So the CD4 count was 206 cells, 206 cells, yeah. Next slide. So our question is, was the switch from TOE to TOD necessary since the woman was already suppressed with TOE? The second question, are there no risks of developing drug resistance to efavirenz or Dolutegravir with all these switches from TOE to TOD to TOE, and probably maybe soon when we have TOD back, we'll switch this lady again to TOD?
Okay, thank you, Lundazi District Hospital, for that presentation. The whole network. Yes.
Dr. Lusa,
Yes, please.
Kapata Urban Health Center is talking, getting some background feedback. The background.
Yes.
Kapata, can you unmute yourself?
There's a bit of confusion.
Please, can we maintain the etiquette? Can we please mute ourselves? We are disturbing the meeting. We can hear your background voices. Please, let's make sure that we mute our devices. Kapata, your mic is still on. Please mute yourselves and mute yourselves, yes. Dr. Lusa, please go ahead.
Thank you, Dr. Mupeta. So to summarize the case, this is a young woman, 27 years old, who tested antenatally on the first ANC positive, and immediately the client was started on treatment, and the treatment at that time was TOE. 6 months later, the viral load was done, and the result was 209. At that time, the guideline wanted every woman, any client who was suppressed, to be switched to TLD. As per guideline, this woman was switched from TLE to TLD. A year later, which was 6 months down the line, the client had another viral load which was done, and the result was TND. At that point, we didn't have TLD.
Okay, I don't see any hand there. Please, if you have any questions, you can unmute yourself and proceed. Okay, so we've heard the questions, and I can see most of the people have joined as institutions. So I can start with the Macha Mission Hospital. What do you think? Please come through. There are questions here. Since this client has a non-gestation, what was the best ART regimen for her based on what we have learned today? Macha Mission Hospital. You can unmute yourself. Okay, we seem to have a challenge with Macha. We can go to Soloway's Urban Clinic. Kindly unmute yourself. And what do you think? Solowezi.
Hello.
Hello, good afternoon.
This is Macha. Good afternoon, sir.
Okay, Macha, please, thank you so much. You followed the case?
Yes, I did.
Okay, please.
I think this client was.
Are you there, Macha? Seem to have lost Macha again.
To start the client on TLD. Continue. Hello.
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 Yes, we can hear you. Could kindly repeat? Since you had missed.
I was saying the best regimen for this client, though we don't know the gestational age, I think it's TLD.
Okay. Any special reasons?
Like
add any of the.
Which one was that? Edgar.
Please go ahead, Macha.
Yeah. Hello.
Well, continue, please.
Yes, I was saying TLD since like we heard from the previous presentation that it does the viral load. It's a good suppressor of viral load. So in a pregnant woman, we are very much concerned on the viral load because we want to suppress it as much as possible to prevent the baby from getting the virus. So I think TLD would have been the best.
Okay, thank you so much. Do you want to also contribute to the second question?
The second question, was it necessary to wait for ultrasound before initiating the client? Wow. I don't think it was necessary to wait for the ultrasound.
Okay.
Uh,
All right. So thank you so much, Macha. Thank you so much. We can now invite. Yes. Thank you so much. Sons of Thunder, Ms. Kazungula, please come through. Sons of Thunder.
Yes, Dr. Perry, how are you?
I'm okay, sir. Please come through. You followed the case?
Yeah.
Yes, so what's your take?
I agree with TLD for question number 1. Question number 2, the ultrasound is not important to wait to initiate a patient. And question number 3, the baselines are nice, but you're going to start this pregnant woman on Septrin anyway. So you're going to put her on Septrin and your TLD.
Okay. All right, is that all?
The only baseline that I would want is the viral load, just to see what we're dealing with. But the Septrin's there for the whole pregnancy. So the CD4 is nice. It doesn't really dictate treatment.
All right. Thank you so much. I know we have a challenge of network, but we are able to get you, Sons of Thunder. Thank you so much. So let's also hear from other institutions. We have Luwingu District Hospital, Northern Province. Luwingu team, would you want to also contribute to the questions? Please unmute and continue. Go ahead.
Yes, on the first question, I think it was the right regimen to start this woman on TLD gestation. Really, we don't have to base really on the gestation. According to the presentation, we've seen that if pregnant women are taking TLD, it has really more efficacy on reducing the viral load, and that's what we want to achieve. I also want to agree with the one who answered from Macha. Then on the second question, waiting for the ultrasound before initiating, really this time we want to take advantage of the issue of testing there and really starting the treatment right away. Then unless you have suspects of, when you look at the clinical picture of the woman, do you suspect any probably opportunistic infections and the like, that will make you probably delay on starting the treatment. But it's not really necessary to wait for the ultrasound before initiating the client. Then on the third one, waiting on the baseline, really the explanation should be really the same. If we are suspecting that probably this one clinically they look like they have an OI, they rule out the OIs and the like, really the baseline they are waiting for, probably they are talking about waiting for the CD4. The CD4 really doesn't have to determine if someone has to start at. So I think the investigations, they could come later, then would see the investigation, then probably we'll need to adjust the treatment. But it wasn't even necessary to wait for the baseline investigations, unless there are other things they are suspecting that the woman might have. Then on a general comment on finding out the gestation, really women can't remember really the date. Some women, they can't remember really the date when they had their last menstrual period, but they could remember a month. So from there, we can just estimate the gestation. Then really doesn't really link the gestation to starting of the regimen. I think they were right on starting on TLD, and it wasn't necessary to wait for ultrasound.
Thank
Dr.
you.
Piri, Choma Prisons has had their hands raised for a long time now.
Yes, I've not just noticed. Thank you, Koza. So thank you so much, Luwingu. So we can allow Choma Prisons. That's where I think the presenters are now logged in. So please, as you ask your question, please also kindly answer the question about the urinalysis. Choma Prisons Clinic, come through.
Hello, Dr. Piri.
Yes, please.
Yeah,
Sure.
sorry, we were left out of breakout room, so we are unable to participate. However, we first should give the data we are able to collect this morning, which we are not captured in this, which may not have been captured in this presentation.
Okay, so you want to make some additional information?
Yes.
Okay, please go ahead and be brief.
Okay, so for the baseline investigations, we did urinalysis and everything was okay. And we also did viral load, which was 96,000. And then for the gestation age, it was 20 weeks. And ultrasound was also done, which was also very normal. Thank you.
Okay, just come through again. You said the viral load baseline was done and it was 96,000.
Yes.
If I got you clear, and the ultrasound was done normal.
Yes,
and
and
then
also
you managed to get,
done.
Okay, urinalysis was also done. Was this at baseline?
Yes,
or,
at baseline.
Okay, what were the results?
For your analysis,
Your analysis, please.
everything was just normal when they did the investigation.
All right, and then you also mentioned that now you know the gestation age. You said
Yes,
it's
which
20
is 20
weeks.
weeks. Yes.
This 20 weeks, is it current or when they were starting the?
It's current.
The current 20 weeks. Okay.
Yes.
Okay. So I think for the benefit of the network, the team has also given us some additional information that they did a viral load baseline 96,000 copies per mil. Ultrasound analysis were also done. These were normal. And currently the pregnancy is estimated to be 20 weeks gestation. I can see there's a hand from Luwingu. Is that the old hand, Luwingu?
No, I just wanted to react to the additional information that has been given.
Yes, please.
Really, on the baseline, I wanted to hear really the CD4 count, really, not the viral load, because I don't think we can use a viral load really as a baseline, unless we want to know probably how long has this woman had the infection and the like, the recent testing and the like. But for the baseline, it doesn't help in any way really when we want to decide on when to start or when to start the treatment. We want
Dr. Priscilla. We have a question on the chat from Jacob Ngambi asking if the switch was done after the viral load was collected. From the presentation, the first viral load at 6 months was 209 copies, and a year later it was not detectable. So the woman was from both viral loads suppressed. Madam Joyce? Yes, someone was coming in.
Yes, I was coming in to answer that one. The viral load, the switch was done after the first viral load was done. When it was suppressed, that's when we switched to TOD.
Thank you. Dr. Peter. Dr. Francis. This is Mwango, expert from UTH. UTH up. We are calling on expert to wrap up on the case.
Dr. Lusa.
Yes, Simwanza.
Can I say something before the expert comes in?
You're welcome.
Yeah. Dr. Lusa.
Yes, please, Mr. Simwanza. Yes, you can go ahead, Mr. Simwanza.
Hello.
We are getting you.
Yeah, this is a very good case from Alundazi district, but I have some reservations for this case. Looking at the theme and the didactic session that we had earlier on in the afternoon, I think we cannot have a case. This is not a case of interest for this particular topic. We've seen that the woman was started on TLE in the 3rd trimester and was switched on to TLD after delivery. So in line with what we got in the didactic session, I have some reservations on the case. We might have picked a case which was not actually appropriate for the didactic session. I don't know how others feel. And there's been some mix-up. We are using the 2020 guidelines. The initially the case was started with the 2019 guidelines, so that's why we have rapid test at 9 months, and all those gray areas surrounding the case. So I don't know if it was, we can actually discuss the effects of DTG in pregnancy, we're looking at the case that actually we picked up.
Thank you, Mr. Simonza, for that concern. I feel it still stands. This is a pregnancy which has progressed, and it has given us a baby who's now negative. So, TLC versus pregnancy, the case still stands. And because it was also the only case which was submitted by Eastern Province, if we had more cases, that would have given us chance to select the one which was more focused on pregnancy and TLD. But as it stands now, this is it's still valid. Also, the mixed up, this is a real scenario. This is a case which happened, and protocols may still change. So people need also to understand in the environment when this client was being seen, and the judgments should be according to the time when this client was seen. As we can see in this case, this is a client who was seen when we had 2018 guidelines. If we judge according to 2020 guidelines, we would think there were some missed opportunities. But if we understand that that time, this client was being seen under 2018 guidelines, then it makes us understand that the protocols are evolving. That is my opinion. There's a question from Margaret Mwanza. She's trying to understand how this woman took it up with all these changes. Psychologically, how was it? Lundazi, any idea? She was on TLE, put on TLD, back to TLE. How did she receive these changes?
The change was received with some negative feelings. She on her side, she took us like we didn't know what was best for her, so we are just doing the try and error. So we still gave out our best counseling. So though our worry is if the next guidance says, no, switch back to TLD, we have available TLD now. We don't know how we look into, how she'll look at us now.
Thank you very much. Lundazi District Hospital, you are protected and covered. You have just to say, this is what the nation has for you, and to provide necessary on adherence, and to understand that we are with the government, and we are moving with the government's protocol and guidance. Any other contribution before we shift to the expert to UTH?
So, Doctor. Hello, Doctor.
Yes, go ahead, Petauke. Lundazi District Hospital, go ahead.
Dr. Mat, yes. I'm having some. Yes, I think this is a real scenario, and those are the things that we are facing on a daily basis. And when we are transitioning the patient from TLE to TLD, we are giving them a good reason that the drug that we are giving them now is the best one. Yes. Now, suddenly, we again send them back to the drug that we are saying it's less potent than the new one. I think surely they did not receive it as good as such. And the question is to remain, next time, what reason are we going to give to switch them back to TLD? But the concern from Mr. Simonza, it's good, but the problem is we wanted also to be sure from the experts, because that is the essence of presenting, to have their opinion. Is it the switch that we are doing safe? Because we are not just doing it for the pregnant women, we are also doing it for the ones who are not pregnant, even men. But is it safe for us to go from TLE, where we know efavirenz was used and the virus were exposed to efavirenz, then we stop for a period of time, then we go back again? Is it safe to do like that? I think that is the main importance of us sharing this presentation. If the expert can give us their opinion to say that, is it safe or not? That is my submission.
Thank you, Dr. Matua, for that contribution. UTH up, would love you to give a wrap up on the case and bring clarification on the pending questions.
Good afternoon, Eastern Province. And I apologize because we were disconnected, so we didn't hear much of the contributions. For the first question, was the switch from TLE to TLD necessary since the woman was already suppressed with TLE? So of course, as we have heard, we are following the guidelines and protocols of the country. So we were switching off. It was correct to switch off because that's what the guidelines said. On the second part, yes, we keep switching off from TLE and TLD. But I think we should also understand that sometimes we have these challenges of drugs. What we need to do on our part is to explain to the patients, especially when they are starting, we explain to them about our situation with regards to the treatment we are giving. Now, if we don't have TLD after switching and we go back, really we should be able to explain to the mothers our situation. They should understand that this drug is out of stock or the stocks are low. We should let them understand that yes, you'll be switched off because they are low, and we cannot let them stay without drugs. So in the absence of TLD and we have TLE, we have to look at the option, which is the best option, for them not to take medicine or for them to take what is available. So that is why we switch. But with good counseling, if we talk to our mothers and they understand that the drugs are low, then we should be able to switch. But when TLD is available, we have to explain, re-explain and tell them TLD is back and we have to switch back to TLD because it reduces the viral load quickly. And because it reduces the viral load quickly, the woman will enjoy quality life, and then we are going to reduce transmission. That is our main objective. So once we explain that to our women, they should be able to understand, because we cannot leave them in vacuum. I don't know if someone else wants to comment. That is the way I look at it, because we'll have to switch on. We have heard TLD is the best, and it reduces viral suppression quickly. So if we go back and leave them on TLE and adherence is not even good, then we'll be encouraging them to what? To have unsuppressed viral loads. Thank you.
Thank you, Madam Joyce, for that good contribution. But Dr. Priscilla, are you on the network?
Yes, thank you.
Dr. Are you on the network as expert? Before we go back to the main room, these are the contributions from the experts. It will be counseling, and counseling again. At each time we need to do switch because either of logistics or either for some other reasons, we need to give clear guidance to our clients so that they get to understand why we are switching. And because of that, they don't take us as if we are doing try and error. They will understand the real reason as for why we are trying to switch them to other regimen, and with room to say, in case we get again to have enough of these drugs, we may still get back to this strong and efficacious regimen. To you all on the network in Eastern Province, we thank you for your contribution as we are getting back to the main room for the conclusion of the day in a minute. Thank you, everyone. Thank you, experts. Madam Joyce, for your contribution and for coming in for Eastern Province. Thank you.
Thank you so much. Welcome back, everyone, to the main session. I sure hope you had quite enough time to discuss exhaustively all the cases in the different provinces. Thank you so much to the provincial hubs for providing leadership and facilitation. And thank you so much to the experts that were able to provide the expert knowledge on the different cases. And I hope that the various presenters, the clinics, the hospitals that presented cases, you've benefited from the contributions that have come through. And so what we're going to do in this session, now we just want to get to sample one of the provinces to give us feedback on how they were able to resolve some of the issues and how they were able to share some issues from their province. So we are going to pick on Lusaka province. Dr. Zimba, would you like to just give us briefly within the next 2 to 3 minutes, you share your whatever you had concluded in your discussion. Then afterwards, we're going to have some 2 or 3 minutes. Dr. Mwango will give his expert view, then we'll wrap up. Thank you.
Okay, thank you, Dr. Ziambo. So Lusaka had a case of a 32-year-old pregnant woman who was diagnosed with HIV at 12 weeks of gestation of age, started on isoniazid TB prophylaxis and TOD regimen. 5 weeks later, she developed a rash that was there. And then TOD and INH were stopped, and then TOD restarted after 2 days, and later on, a suspected diagnosis of bacterial meningitis and to rule out hepatic encephalopathy was made. So in the group, we discussed and clarified a few things about the patient himself. And we discussed on the importance of TLD as being one of the first preferred regimens in treating newly diagnosed pregnant women and women because of its advantages of causing early viral suppression. Its advantage over a high genetic barrier. It doesn't get a DTG-based regimen. Then when we looked at the case itself, we saw that there were some gaps that could have been done better. For instance, we should have referred the patient earlier for specialists or consulted the specialist earlier in time, because at Matero, we were unable to do even an ultrasound at the time and able to do an LP, which we thought would have benefited from the patient. And then certain tests like a creatinine was done, but we didn't calculate the creatinine clearance that needed to be done at the time. And therefore, this case highlighted, it was a very complex case. It highlighted the benefits of using TLD in regimen in terms of causing viral suppression in the discussion. It also highlighted the importance of consultation and referral, urgent early referral at the time. I think that would be my summary for us, Dr. Ziambo. I think I've been in under a minute. Thank you, Dr. Ziambo.
Excellent, Dr. Zimba. You've given us a certain picture as if we were joining with you in Lusaka. And most people agree with me. We're able to see what you were discussing there. Thank you very much, Lusaka. Next week, we'll be able to hear from another province, maybe Western, maybe Southern, maybe Eastern. So just get ready to be able to give us briefly on what you discussed. Dr. Mwango, would you like to just give your final remarks considering some of the cases that you probably have seen so far?
All right, thank you so much, Dr. Ziambo, and to the network for the helpful discussions, which really make us focus on what we are doing. I just wanted to point out that, the advantages of using Dolutegravir in pregnancy are very immense, and we are getting more and more evidence that makes us more confident that what we are doing is the right thing and it is helping our patients. But I would also like to emphasize that there's a double-edged sword to those advantages. Like, for instance, for DTG to be able to reduce the viral load very rapidly in a very short time to very low levels, it can trigger iris. And that's something that you should also keep in mind. As much as we want to reduce these viral loads very quickly, there's also a downside to it where you might see iris if you have not fully screened and treated a patient who may have underlying opportunistic infections. So just keep that in mind as well. And I think the last case that we saw there is one of those situations where you see a patient, when you start them on the dolutegravir-based regimen, they start deteriorating very fast. Maybe it's because we have not fully managed all the opportunistic infections. So just keep that in mind as well. Other than that, remember the points, the key messages we had. DTG is safe in pregnancy, whether peri-conception period or during pregnancy, especially during pregnancy. And it helps us meet the main goal of ART in pregnancy, which is having a good, healthy mother who delivers an HIV-negative child. I think that's the points I would like to really stress at this point, and to thank you everybody for the time and opportunity. Dr. Ziambo.
Thank you so much, Dr. Mwango. We appreciate your expert knowledge that has been able to be shared with the various facilities and centers around the country. This has made a very significant contribution in building capacity among our facility staff. Thank you so much. We continue to thank and appreciate our various experts that we had in our midst. Thank you so much to our ever so green midwives who were available in the hub. Thank you so much. We appreciate your support and your presence. Thank you very much. And also to the experts that were in the various provinces, thank you very much. We appreciate your support, and we look forward to always having you with us as we continue to present. Next week, we'll have a presentation on mental health, and we will be discussing a number of issues around mental health care. And I think we'll have a great presentation. Dr. Simenda will be the one to present. Dr. Simenda, yes, will present, and we look forward to that. I think with that said, we've come to the end of our session today. Thank you very much all for connecting. Have a good day. Thank you.